hello and welcome everybody to today's webinar, Lifetime Considerations for the Autistic Patient. This session is hosted by Medical and Life Care Consulting Services, a Massachusetts-based case management and nurse consulting firm. We're so excited to have you join us for this presentation. My name is Amanda Barnett, and I will be the moderator for today's medical legal webinar. Our medical legal webinars are designed for attorneys, claims professionals, and litigation stakeholders, highlighting how medical evidence, future care needs, and cost projections are evaluated to support clear, defensible medical legal conclusions. This session is expected to run for approximately 50 minutes, with an additional 10 minutes provided for questions and answers at the end. After the webinar, we will share a recording, a certificate of completion, and a link to complete a quick survey for a CEU credit if applicable. For this year's second Behind the Case session, Lifetime Considerations for the Autistic Patient, we're pleased to welcome our very own Cindy Fleury and Cindy Bourbeau. Cindy Bourbeau is president and founder of Medical and Life Care Consulting Services, a registered nurse, a certified rehabilitation nurse, a certified case manager, certified nurse life care planner, legal nurse consultant, and a certified health professional life care planner. She has worked as a nursing professional for over 40 years and currently leads Medical and Life Care Consulting Services, a practice of professional nurse consultants and case managers who provide medical case management, medical legal services, including life care planning and ancillary professional nurse consulting services, as well as vocational expert witness services and case management. Cindy founded Medical and Life Care Consulting Services in 2001 and is presently a member of the American Association of Nurse Life Care Planners and is a board member of the Universal Life Care Planner Certification Board. She is also an active member of the Association of Rehabilitation Nurses, the International Association of Rehab Partners, and the Case Management Society of America. Cindy Fleury, Director of Education and Professional Development, has over 30 years of case management experience within workers' compensation and has supported hundreds of medical legal cases with injuries and illnesses ranging from a failed back injury, burns, severe TBI, and spinal cord injuries. Cindy is a registered nurse, certified nurse case manager, and a certified nurse life care planner. Cindy applies her extensive experience to creating and implementing training and professional development programs for the MLCC nursing team. Cindy also serves as a nurse consultant and expert witness for medical legal cases. And with that, I will turn it over to Cindy Fleury.
Thank you, Amanda. Next slide, please. The webinar today is going to focus on how autism is diagnosed, define characteristics of the autistic patient, identify common behaviors of the autistic patient, identify complications, treatment modalities, including non-traditional treatment options. Next slide, please. What is autism? Autism spectrum disorder is a condition related to brain development that affects how people see others and socialize with them. This causes problems in communication and getting along with others socially. The condition also includes limited and repeated patterns of behavior. The term spectrum in autism spectrum disorder refers to the wide range of symptoms and the severity of these symptoms. Autism spectrum disorder includes autism, Asperger's syndrome, Heller syndrome, and a form of widespread developmental disorders that are not specified. Next slide, please. The causes of autism are unknown, but it is believed to involve a combination of genetic and environmental factors. There's no medical test for autism, like a blood test or a diagnostic study. A diagnosis autism spectrum for diagnosing autism spectrum disorder. So how is it diagnosed? Next slide, please. The behavioral symptoms of autism spectrum disorder often appear early in development. Many children show symptoms of autism by 12 to 14 months of age, sometimes earlier. If a child is displaying signs of autism, they will likely be referred to a specialist, which could be a child psychiatrist or psychologist, pediatric neurologist, or a developmental pediatrician. Because autism spectrum disorder symptoms and severity can vary widely. It may be hard to make a diagnosis. There's no specific medical test to diagnose autism spectrum disorder. Instead, specialists may observe the child and ask how the child has developed or changed over time in terms of interacting socially, communicating, and behaving. They may give the child tests covering hearing, speech, language, level of development, and social and behavioral issues. They may present structured social and communication interaction to the child and score the performance. They may include other specialists in coming up with the diagnosis. They may recommend genetic testing to rule out an underlying genetic condition. Some individuals don't get diagnosed till later in life. While an autistic diagnosis can only be given by a healthcare professional, there are several screening tools that can alert parents, caregivers, and autistic people to potential to clue you in on potential symptoms of autism. Early screening for autism can impact access to services and supports, which in turn can influence future outcomes for autistic individuals. For an example of some of the questions on the screening tool may include, if you point to something across the room, does your child look at it? Have you ever wondered if your child might be deaf? Does the child respond to their name? Many parents are unaware of these early signs of autism and don't start thinking about it until their child doesn't speak at a typical age. Next slide, please. What are the signs of autism? Children with autism often have problems with communication skills and in dealing with other people. They might repeat certain behaviors and might not respond well to change in their daily activities. They often have different ways of learning, paying attention, and dealing with the world around them. Typically, the signs and symptoms of autism begin during early childhood and last throughout a lifetime. They may have trouble being interested in other people. They may avoid eye contact. They might want to be alone. They may have trouble understanding feelings. They may be unable to talk. They may not be able to express their feelings, might not want to be held or cuddled. They may appear to be unaware when people talk to them. They may be interested in people but not know how to talk, play, or interact with them. They may repeat words or phrases.
Cindy, it looks like we had some technical difficulties. I think you cut out a little bit, so you might want to back up a few minutes and get back to talking about
the signs of autism. Children with autism often have problems with communication skills and in dealing with other people. They might repeat certain behaviors and might not respond well to change in their daily lives. They often have different ways of learning, paying attention, and dealing with the world around them. Typically, the signs of autism begin during early childhood and last throughout their life. Some of the symptoms of an autistic child may include them not being interested in other people. They may avoid eye contact. They may want to be alone, may have trouble understanding feelings. They may be unable to talk. They may not be able to express their feelings, might not want to be held or cuddled. They may appear to be unaware when people talk to them. They may be interested in people but not knowing how to talk, play, or relate to them. They may repeat words or phrases, or repeating words or phrases in place of normal language. They may have trouble talking about their needs using typical words. They may not look at objects when another person points to them. They are unable to adapt to change in their routines. There are three levels of autism. Individuals with autism level 1 are often what people once referred to as mild cases of autism. They may be able to handle many aspects of daily life independently, but still experience significant challenges in social situations or adapting to change. For an example, A teenager with autism level 1 might do well in school, but find it exhausting to navigate friendships or group projects. Adults might struggle with reading social cues at work or managing unexpected changes in their routines. They might have restricted interest or repetitive behaviors that provide comfort but can make flexibility difficult. Support at this level often includes social skills training, structured routines, and therapy to improve communication and self regulation. Asperger's syndrome falls in this category. Children and adults diagnosed with Asperger's have difficulties with social interactions and exhibit a restricted range of interest and/or repetitive behaviors. Asperger's can be particularly difficult to detect in people of all ages. Children are often overlooked because language development, while sometimes odd, is not delayed, and there is no obvious cognitive impairment. Older individuals might be struggling with social challenges, but problems may be difficult to detect unless a more serious problem like depression emerges. Autism level 2 requires more substantial support. People with level 2 autism need more consistent and intensive support in their daily lives. Their challenges with communication and adaptability are more pronounced, and their repetitive behaviors may significantly interfere with social and occupational functioning. For instance, a child at this level may speak in short phrases or rely on nonverbal communication. They may struggle to adjust when routine changes or when exposed to sensory triggers like loud noises or bright lights. Support for autism level 2 often involves speech therapy, occupational therapy, and structured behavioral interventions such as ABA therapy. These therapies can help individuals build essential life skills, manage sensory sensitivities, and develop alternative communication strategies. Level 3 autism is more common in a male than females. This level represents the highest level of support needs. Individuals at this level experience profound challenges with social communication and adaptability. They may have limited or no verbal communication and rely on assistive devices or other forms of alternative communication. May have difficulty understanding and responding to social cues. Severe autism can lead to significant difficulties in social interactions, including a lack of interest in forming relationships. Repetitive and restricted interest in activity. These can include repetitive movements, fixations on specific objects, inflexibility, resistance to change, rigid adherence to routines, sensory sensitivities. Individuals may be overly sensitive to sound, light, textures, or other sensory inputs, leading to distress or behavioral issues. Aggressive or self-injurious behaviors. Challenges with daily living like dressing, eating, or sleeping. Their routines and repetitive behaviors are often critical for comfort and stability, and changes can lead to significant distress. Many individuals at this level also have co-occurring intellectual disabilities or medical conditions that require continuous care and supervision. These may need to be included in a life care plan. So what's the cure? Unfortunately, there is no cure for autism spectrum disorder, and there is no one-size-fits-all treatment. Treatment seeks to support the child's learning, development, and behavior. Getting treated early during the preschool years can help the child learn critical social, communication, functional, and behavioral skills. The range of home-based and school-based treatments for autism can be overwhelming, and the child's needs may change over time. Next slide, please. People with autism display certain patterns of behavior. They commonly make the same movement over and over again, such as rocking, spinning, or flapping their hands. Sometimes these behaviors can result in hurting themselves, such as biting or headbanging. They create specific routines or rituals and become upset at even small changes. For an example, in the movie Rain Man, Raymond, who is played by Dustin Hoffman, has a meltdown because he is missing the TV show People's Court. He watches it every day at 4, and as the time approaches, he fears he's going to miss the show and becomes more and more anxious. To the point, they knock on a stranger's door and ask if they can come in just to maintain this routine. People with autism tend to be clumsy, not coordinated, move in patterns that aren't usual, such as walking on their toes. They may have unusual stiff or exaggerated body language. They may be fascinated by details of an object, such as the spinning wheels of a toy car, and they don't know what the object is for or how it works. They may be sensitive to light, sound, or touch, but may not be affected by pain or temperature. They don't mimic others or take part in make-believe play. Fixate on an object or activity with unusual intensity or focus. Prefer specific foods, such as eating only a few food items, not wanting to eat foods with certain textures or colors. There are many treatment options available for the autistic patient. Behavioral and communication therapies. Many of these programs address a range of social, language, and behavioral difficulties linked with autism. Some programs focus on reducing challenging behaviors and teaching new skills. Other programs focus on teaching children how to act in social situations or communicate better with others. Applied behavioral analysis can help children learn new skills and adapt these skills to many situations by motivating them with rewards. Educational therapies. Children with autism spectrum disorder often respond very well to highly structured educational programs. Successful programs usually include a team of specialists and various activities to improve social skills, communication, and behavior. Preschool children who get intensive, individualized behavioral treatment often show good progress. Family therapy may be needed. Parents and other family members can learn how to play and interact with children who have autism in ways that support social interaction skills, manage challenging behaviors, and teach daily living skills and communication. Speech therapy. This treatment depends on the child's needs. They may focus on communication skills or assistive communication devices. Occupational therapy to focus work on activities of daily living. Physical therapy to make movement and balance better. Psychologists can recommend ways to manage problems with behaviors. Medicine can't make the core signs of autism better, but specific medications can help control symptoms. For example, certain medicines may be prescribed if your child is hyperactive. Sometimes healthcare professionals prescribe antipsychotic medicines to treat severe behavioral symptoms, or they may prescribe antidepressants for anxiety. Research shows that melatonin can help with sleep issues related to autism spectrum disorder. Alternative medicine. Why not try unconventional treatments? Some of these therapies may be helpful, although research has not proven that these therapies work. Creative therapies such as art or music, along with educational and medical therapies, can make a child less sensitive to touch or sound. Sensory-based therapies. The therapist may use brushes, squeeze toys, trampolines, and other materials to stir the senses, such as touch, balance, and hearing. Massage. While it might be relaxing, there isn't enough evidence to show that it improves symptoms of autism. Pet or horse therapy. Pets can give the child a companion, although more research is needed to determine whether being with animals improves symptoms of autism. Providing a companion can offer comfort and may improve anxiety. Acupuncture. This treatment has been used to improve autism disorder, but research doesn't show that it works. The bottom line is try different modalities and find what works best for that individual. Complications of autism, difficulty in school and with learning, may not be able to get a job, not being able to live on their own, social isolation, stress within the family, being a victim, being bullied. Individuals with autism are at a higher risk for exploitation due to difficulties interpreting social cues, hidden intentions, and tendency toward honesty and trust. Things to consider in a life care plan. Can the individual live on their own? Have they been evaluated to determine this? Do they need 24-hour supervision? Are they capable of participating in a work program? Are they capable to go to college? Do they need additional support to be successful? You might want to consider a voc rehab specialist for individuals that are capable of working to determine what their skill set is, their educational level, and employment interest. If moving on to a higher level of education, do they need a tutor? If they are not able to live independently, do they need help with personal care, or is it more supervision and direction? Do they need a home health aide versus a companion or a homemaker? Consider a group home if appropriate. Many group homes are state funded, but there are some out there that do accept private pay. There are a lot of adult day programs for autistic patients, case management services to assist and oversee their care. Can they drive? Do they need transportation? A driving eval may need to be considered. What treatment is best for them? What works for this individual? Do they need ongoing, consistent treatment or periodic treatment throughout their lifetime? What is their cognitive function? Cognitive function refers to the mental processes that allow us to carry out any task. They encompass the means by which we perceive, think, remember, and learn. These functions are essential for our interaction with the environment and our understanding of it, and develop through childhood and adolescence. Cognitive function includes memory, which is storing information, attention, focusing on stimuli, language, communication, executive function, planning and decision making, perception, interpreting sensory data, and reasoning. Many individuals are at risk to be taken advantage of as they are unaware of social nuances and are an easy target. A neuropsychological evaluation may be a consideration to discern whether or not they are capable of managing their own IADLs independently, such as finances. Do they need a guardian or a conservator? When developing a life care plan, you may need to include these types of services. What's the difference between a guardian and a conservator? Guardianship focuses on personal, daily care, like health and housing, for incapacitated adults or minors, while a conservatorship focuses on managing finances, assets, and property. Guardians can be appointed temporarily. If parents or family members are going to be away for an extended period of time or otherwise absent, they can name a temporary guardian to look after the individual. This is done either by filing a guardianship application with the court or penning a letter of guardianship. This document allows the parent to grant short-term custody, care, and decision-making over their child to another trusted adult. The letter spells out exactly what responsibilities the guardian will have and for how long. Appointing guardians ensures the individuals are looked after when their parent or family are unable to provide care. Guardians can be family members or close friends. Non-relative guardians are court appointed. A non-relative must petition the court proving they are qualified and that the appointment is in the individual's best interest. This may occur when no family is available, the family is unfit, or in contested cases where a neutral party is needed. If there is no one that is known, the court may appoint a guardian ad litem or a public agency to act as a guardian of last resort. In many cases, private professional guardians with backgrounds in social work or law, particularly if the person has assets to pay for these services. A non-relative conservator is a court-appointed individual or entity, often a lawyer, professional fiduciary, or public guardian, responsible for managing the finances or personal affairs of an incapacitated adult. They are appointed when family members are unavailable, unsuitable, or if conflicts exist that requires an independent, unbiased party. Professional conservators or fiduciaries are licensed individuals who manage estates, finances, and personal affairs for a fee. Attorneys that specialize in probate or elder law are often appointed to handle complex financial or legal matters. Public guardians or public officials, when no family or friends are available, the court may appoint a state-affiliated agency. Close friends, while not blood relatives, they may be appointed if they have a close, trusting relationship with the person needing care. Guardians and conservators are entitled to reasonable compensation, and research may be needed to determine this cost to be included in the plan. At this time, I'm going to hand it over to Cindy Borbo, who's going to discuss a case study.
Hi. So before we get into this specific case, I just want to say, so I've worked with my background in rehabilitation case management, I've worked with children with autism in a variety at a variety of ages. So from young age of 8 or 9 until 22 years old. And so, you know, every single situation is individual. So oftentimes you can have a diagnosis of autism. A lot of times you can have that is independent and no other medical issues are really going on, or it can be with varying levels of intellectual disability and other medical complications. So it's very specific to each case. The environments that we get involved in can be a home with the primary parents. It can be in a home with an alternative relative. It can be in a group home for people with autism, or even subsidized housing, depending on the level of intellectual disability. Some people are living independently with just financial oversight. Or it could be also, you know, a very severe situation where the person is having behavior issues because of things that have happened in their lives. So they could be in a acute facility for patients with behavioral issues. They could also be in a group home affiliated with that. And I've worked with people in different situations, similar, you know, those types of situations. Or it can even be in the foster system, because sometimes maybe there's some problems in the home and the child is taken out of the home. And so then you have a child that grows up in the foster system with a special foster parents. And then when they get into adulthood, they also then need a special setup where parents, these foster parents could actually continue to work in the adult setting for these children. So this specific case study is a combination of about 3 different patients. So it's not about anyone specific, but just the types of situations that can happen with someone who's very involved. So because I'm in rehabilitation, it's very rare that I would just get a straight, you know, situation where it's just autism. At some point in the case, there's been some medical issues why I've been called in to assist, right? But this is a 14-year-old girl, Marissa, and I started working with her when she was about that age. She's now older and has gotten out of high school. She had a diagnosis of a traumatic brain injury from birth, seizure disorder, global developmental delay, intellectual disability, autism. She had dysphagia. She was able to be fed and eat efficiently pureed foods, but liquids she had difficulty with. She is nonverbal. She had also cardiac problems from birth, bowel and bladder incontinence, and also post-delivery, she had a stroke with hemiparesis. Next page, please. So there are all types of things that people need that have these diagnoses, right? So there are to deal with a traumatic brain injury and a seizure disorder, obviously, depending on what level they're at and when you start working with them, there's always going to be therapy involved in the process intermittently throughout their lifetime. So as she was 14 years old when I started working with her, was still in the school system, and she was receiving PT, OT, and speech in the home. She was also receiving some outpatient physical therapy because she had had an illness and ended up having a decrease in functional ability during that time. And so she was having an episodic treatment of physical therapy immediately post that hospitalization. In addition, the other types of treatments that could happen, there are many. So in addition to therapies, we talk about future medical treatment, which would be physician's appointments, diagnostics and labs, durable medical equipment, home care services, which can be home health aid and other types, facility care, like I talked about. There are multiple sites that these patients will live, and we'll talk about some of those. Transportation issues, because of the impairments that specific patient has, there's architectural modifications, orthotics and prosthetics. There could be surgical and medical procedures, periodic hospitalizations because of swallowing issues and aspiration pneumonia, and pain in her right hip she also had. Next page. We're going to get into this a little more specifically. I was trying to do it without changing the pages, but that's not good. So as far as evaluations and therapies needed, so she had right-sided hemiparesis, so she was using an AFO. She was ambulatory, and she was not using assistive devices. But if she was a higher level functioning, I think she would have benefited from that. However, she could not understand how to use a cane or how to use a walker. So basically, a caregiver walked with her everywhere that she went. So physical therapy is needed when her status deteriorated. And that I anticipate will continue intermittently throughout her lifetime. I didn't put occupational therapy down here, but it should be included also. So the other problem that she had was she used to feed herself and she used to drink thickened liquids independently. However, because of a hospitalization that she had, I think that possibly what happened was she was force fed. They were trying to get her to eat. And when that happened, she just backed off from everything, because obviously with any change in the environment or change in people taking care of them, it can trigger a lot of things, and behaviors are one of them. And so she really lost a lot of skills with each episode of illness that she experienced. And so therapies had to be put back into place. Same thing for feeding therapy and communication. Those were used intermittently during the time period that I was working with her, which was about 8 years, I'd say, maybe longer than that. Because of her behaviors, So she did not make good eye contact. She was nonverbal, so she was not able to speak. She did make noises and she did laugh, but she had a lot of behaviors. So every time caregivers were changed or someone in the family got sick and was not around, anytime there was a change in the in their in the setting or in the situation that was going on, it triggered behaviors. So every new caregiver had to be trained on how to handle her behaviors. So obviously a behaviorist would come in a couple times a year, up to 4 times a year, even to evaluate the patient, make changes to a treatment plan. And then a technician, in her case, came in 4 days a week for 2 hours every afternoon after she got up from her nap after school. She would then meet with a behaviorist. She did physical therapy. She did hippotherapy and on the weekends and participated in pool therapy also. So at sometimes she was doing better than others, and her treatment would change accordingly. Now, in the school system, obviously she had an IEP program throughout her school years. However, because of her intellectual disabilities, really her program was really focused towards life skills. So she would bring things to other classrooms for teachers. She would make copies of things. She would clean up areas. She would do things that she needed to learn to live and participate in her everyday. So that could be folding clothes. It could be, doing the laundry, all different types of life skills. Getting her food out of the refrigerator and working with an aide to prepare it. In addition, because of her hemiplegia, she used AFOs. She used a wheelchair for distances. Even when she was out ambulating in the community, she always had a wheelchair behind her because when she got tired, she just got tired and she went down. So she was in the wheelchair a lot when she was out in the community. So she would go to a wheelchair clinic. Next slide. So types of physician care that would happen would be, obviously, she had a seizure disorder, and she had both grand mal and focal seizures. So a neurologist was following her. And obviously, as she aged and grew in size through those growth and development years, adjustments had to be made to her anti-seizure medication. So that was a very active process when I was working with her. Really, her gatekeeper for everything was the primary care, the pediatrician, and that pediatrician assisted in all different areas as her labs were off. She had cardiac issues that occurred. All different types of things happened because of fluid imbalances, and if she got sick at all. She also had a slow gut, so all those kind of things had to be addressed. Cardiac problems from birth, so she saw a cardiologist regularly. Orthopedist-wise, with complications, there was a decrease in her functional ability, and so her gait changed. She seemed to be leaning more. It seemed like there was more weakness on the function of her flexion and extension of her foot or her knee strength. And so an orthopedist would be consulted and then therapy would be ordered. Physiatry was also called in intermittently to address tight muscles or tendons, and Botox was also trialed. Her communication skills were very poor. However, periodic neuropsych evals are done on a different level to evaluate her response to her environment. So those are needed. And obviously, with all the orthotics that she used, an orthotist was involved in her care. Next page. So diagnostics and labs that regularly occurred would be blood work for anti-seizure medication. It would also include a metabolic panel and a CBC just to monitor for any potential changes that are occurring in her kidney function, cardiac function, and whether because of a growth spurt, maybe her anti-seizure medication was not heavy enough at that point, and the dosage needed to be changed. Periodically, a 24-hour EEG would be done, or a regular EEG, with every change in seizure frequency, because obviously with changes in growth through growth and development, those were definitely needed to be done because she ended up having multiple seizures during that time and needed adjustment to her medication. For her heart problem, she would have EKGs and echocardiograms to make sure that no changes were occurring because of the dysphagia. So she was able to take pureed, sort of mechanical soft with fluid in it. And she originally used to feed herself, but had deteriorated, as I said. And by the time I stopped working with her, she still had not she had not gotten back to feeding herself. And I really think that consistent caregivers is one of the reasons why we weren't able to achieve that, but I'll talk about that when we get to that section. So when there was concern for possible aspiration, a modified barium swallow will be attempted again. Again, sometimes they couldn't complete it because the patient just was not cooperative. And constipation was a big problem also. And so periodic KUBs would have to be done because the bowel and bladder function had to be followed closely because of the problems with fluids and making sure that she was getting enough fluids every day. Next slide. So durable medical equipment. There are so many things that a patient could need, right? But in her case, she had a wheelchair cushion. It was a manual wheelchair. She had a fully electric bed with sides, a very durable shower chair because she was a big girl and she would like to bounce. And so she actually broke the floor of a shower stall because she bounced in a shower chair. She's broken shower chairs. A handheld shower head is necessary. So a really durable floor, something that's very thick and hard, is really what's needed, not those types of showers where you're just popping in, the fiberglass. You need something that's really strong. Additional grab bars getting in and out of the shower were also utilized because she did have mobility. Another problem that she had was the brightness or the flashiness of the handles and stuff in the shower can be a problem for some kids with autism. And so they want to play with that and you can get burned very easily. So we ended up taking the controls out of the shower for that patient. She was incontinent of bowel and bladder. We did trial toilet training multiple times during the time I was working with her, and they were not successful. And so she was really on a toileting a toileting and pericare schedule every couple of hours. We used chucks, both disposable and cloth, gloves, obviously, barrier creams. Because of her seizures, she lived with her family, and her parents were worried about her having a seizure and them not being aware of it. And so a seizure monitor was used. And then also because she was very mobile and walking around, all the doors had to be locked at all times. And she actually was able to open doors. One of the patients that I was working with actually was able to open the windows on the second floor and go out the window and land in the bushes, thank God. But special locks for windows and alarms for windows are also available out there so that you really can keep them in a nice, secure spot and not worry about, them eloping. Next slide. Next slide. Oops, did we do it? Oh, here we go. Okay, so adaptive eating equipment, obviously plates and utensils, drinking cups. We're still working on trying to get her to drink, and so we're going to have all of those things. Even if they're not doing it, you want to keep working at it, because at some point there will be a breakthrough possibly, and you don't want to just assume she's never going to do it again, right? She did it once. There's no reason why she can't do it. We build up utensils to make it easier. We use blenders and mixers because, the food has to be well pureed. We don't want them choking or aspirating. She also had a big problem with drooling. And so excessive drooling. So we use bibs for that. We use thickeners for fluid. And family members would even provide liquid through a syringe when she didn't want to swallow. We use gait belts for walking, seat belts in the wheelchair, extra special seat belts in the car. Let's see, an iPad for communication and also for, stimulation. Because she was good at moving furniture, we also obtained furniture. There's furniture that you can purchase out there. You fill it with sand, and then it can't be picked up and thrown, or so that there's no problem with that. We also got a commercial table for the kitchen table, which was sturdier. So you want sturdy items, so that if there's any behaviors that occur, then they're not breaking things. So obviously we want this child to be as stimulated, or adult as stimulated as possible. So you have to find out what their interests are. So she enjoyed being read to. She enjoyed toys and sports equipment and simple games. So her behaviorist would actually identify some activities that she could do, and then the team would do that with her. So in every one of the houses that I work in, I set up a binder for the care team, and that identifies what her behavior plan is, and then what the treatment plan is for all day, what you want done every day, what should be done for this child. It's a way for the family to be able to see that these things have been happening. So many of our things are very high tech now. And so often home care companies will automatically put people on, they have electronic record keeping. But that doesn't help the family know. So when the family comes home, they want to know what's been done during the day or at nighttime, and where there are problems. And so that's what the binder's for documentation of all that. Next slide. And then obviously medications are individual to that patient, but she didn't have a lot of medications, but she did have cardiac meds and then rescue medication for seizures and a seizure plan in place. So if a home health aide is caring for that patient, basically there has to be someone in the house who can enact the seizure plan if a seizure occurs, and do rescue meds. And it has to be a family member, and obviously calling 911, calling the family member that's not there, who's in charge of the medical issues. But daily medications are often, and they're always given by the family, not a home health aide. And so the home care services can be varied. They can include a home health aide. So if you've got a child in school that has to get up and go to school during the day, first thing in the morning, obviously it's hard to get a family together and out the door in addition to a child with significant disabilities. So I'll always put a home health aide in the morning before they go to school. In her case, she had it before she went to school. So that person helped with feeding her and also, dressing her and washing her to go to school, and then getting her out into the bus. And then she would go to the school for the daytime and then come back in the afternoon, take a nap, and then, or there's also behaviors that would come in 3 times a week or 4 times a week. and the behaviorist would work with her with different things for a couple hours. That is usually with a home health aide present, because someone else from the home has to be present when the behaviorist is working with the child. And then at bedtime, someone to help with bathing and dressing, getting ready for bed. Skilled nursing is needed if there's not a family member that can set up their medications. It's important to have that done and have the bowel and bladder function assessed on a regular basis. Case management is involved with physician appointments. I went to all her physician appointments, obtained their treatment plan when there was a problem, kind of facilitated resolution of those issues that were going, and also manage the home health aide care in the home. So that would include interviewing home health aides, interviewing home care agencies. The home care agency is supposed to be responsible for what goes on in the home, but there isn't often a lot of direct oversight. And so that oversight has to be done by someone, and it's a case manager usually. And so if there are some things that are happening repeatedly, whether it be infections or rashes or whatever, there's something that's being done wrong regarding their care. So we want to make sure that we get a case manager that's assessing these things and making sure to train the staff to do what they need to do correctly. And so obviously during the school years, growth and development years, children can stay in the school system to age 22. And then at that point, they then that year, not necessarily like the day they turn 22, but that year they will then transition to a day program or a working program, depending on their level of care needed. But in this case, it was to go to a day program. And then obviously on the weekends, you're providing more care, right? Because for whatever reason, if they need overnight supervision in case of seizures or behavior issues that happen at night, or it could be that they sleep all night and then just need somebody there during the daytime so the family can continue to participate in all the other things that their other children need to do. Okay, next slide. Facility care. So obviously in this case, the family was dedicated to keeping that patient in the home. But as I said, there are a lot of people where there's not the opportunity for them to be managed in the home. So there are group homes. There is the foster system when there's problems in the home. So they'll start out as a child in the foster system, get through their growth and development years and graduate, and then after that get into an adult fostering situation. Or if their needs are really intense because their behaviors are intense, they could be in a facility that deals with behavioral management and gradually be worked towards being able to be in a group home and out in the community again. So in her case, for transportation, we used a special seat belt for normal car driving, with the doors and the windows locked. She also would take the bus. So both of those, she had a special seat belt in the bus also. So transportation can be via the school. They'll provide it through a day program or through community services. Obviously, a modified van for transport purposes is important for family function. So when they want to go on vacation and they're taking that child with them and a caregiver, then, you need a van for that, especially if they're in a wheelchair for long distances or even just constant use of a wheelchair. Oftentimes in the group home, they'll provide the transportation. But usually it's around where the group home is. It's not for distances. So like go see family if family's not around. Next slide. And then architectural modifications. In this home, there were widened doorways. We needed to do sturdy furniture. We did a stair lift to the basement and to the second floor. And then an accessible bathroom. This child liked to use a tub, so there are special lifting apparatus that actually the child can sit on, can be transferred onto to sit on, and swing their legs over into the tub and then be lowered into the tub. So that's another option versus a shower. She really enjoyed having a bath. So that accessible bathroom is important. And then orthotics and prosthetics and AFO for the right foot, and possibly a KFO due to knee weakness in the future, because that was happening periodically. The problem is that oftentimes that external stimuli is difficult for children with autism or adults, anyone with autism, to tolerate that sensory issue. So next page. And then obviously there's a lot of different problems that occur. Everybody's an individual, but for excessive drooling, surgery could be needed to resolve that. Often it's treated with medications or Botox injections. In her case, she had Botox injections. Then there's a salivary duct ligations that can happen where they can either relocate that duct or take it out to decrease this. She was treated with medications ineffectively, and they were trialing Botox. And then hip pain. So she had a lot of hip pain, and it was found that she started developing some dysplasia because she wasn't walking a lot. And so that is treated with periacetabular osteotomies or femoral osteotomies. And she had that surgery and had decreased pain and increased mobility afterwards, which was great. Hospitalization. So with any colds and illness, she was prone not to get enough fluids and needed hospitalizations. And that just sets up a whole nother problem. So it's really great if it's possible that there's a caregiver that's caring for them in the home. I send them to the hospital with them, and they stay with them 24 hours a day. So at least they have their same routines, even though they're in a different environment. And the best medicine is to get them home into their regular environment again, so they're not thrown off. Next page. And that's it. And these are some resources that were used. And I used up all the time talking about this, so I'm sorry. I don't know that if we have time for questions or whatever, but
no, that's great. Thank you so much, Cindy. Both Cindy's for sharing so much information and insight about autism. If any attendee today would like to receive a CEU credit for this presentation, please scan the QR code on the screen to be brought to a survey to be completed for this credit. So thank you all for joining our second Behind the Case medical legal webinar of 2026. A playback of this webinar will be available within 48 to 72 hours. And for more information about our webinars and on-demand resources, please visit our website, medicalandlifecare.com, where you will find a wide range of medical legal resources. And our next session will be on August 26th with Dr. Neil Alpiner, Pediatric Life Care Planning and Treating Children. And with that, we will conclude today's webinar with about 2 minutes to go. Thank you both again, both Cindy's, and we look forward to the next session. Thank you so much.